Next, I have the distinct pleasure of inviting Marina, who's going to share cerebrovascular evaluation of pediatric stroke, talk about some cerebral hemodynamics and how we assess highways and parking lots in pediatric brains.
Thank you so much. It is my pleasure to talk today about cerebrovascular evolution in pediatric stroke. To be very honest, I'm out of my comfort zone. I usually use point of care ultrasound to guide hemodynamic therapies. So I'll try to build up a bit of the lacking evidence that it's right now in this topic. And I'll try to use some of Shishir Smanova and Virginie Planté knowledge and just build it up from there, because as you will see, there's not a lot of evidence. So we're kind of all sharing kind of the main articles that we are just reading and learning from. So just I will put the presentation in full mode. Just triple check you guys can see that.
Yes, thank you.
Perfect. Fantastic. So pediatric stroke is a huge topic, very different perinatal stroke than childhood stroke. As you can see, the age range when we talk about perinatal stroke is 28 weeks of gestation to 28 days of life. So it encompasses also the kid that has not yet been born. 80% of those perinatal strokes are arterial ischemic infarction, and 20% of them, it's a combination of cerebral sinus venous thrombosis or hemorrhage, and that's not accounting for the preterms IVH and the subarachnoid hemorrhages. The incidence is extremely variable depending if you live in a developed country or in a developing country. So it can be anywhere from 1 every 4,000 to 37 every 100,000 live births. The symptomatology, it's the most tricky part because it's so indefinite. So it can be anything from irritability, poor feeding, focal seizures, encephalopathy. So it makes the diagnosis very difficult and usually fairly delayed. In childhood stroke, we take these kids that have already been like around the month of age up to 18 years old. So you can imagine the wide range of sizes and bodies that we are dealing with. The type of stroke, it's a bit different when we talk about childhood. It's 50% ischemic, mostly cerebral arteriopathy, a lot of sickle cell that have 100-fold risk to actually have ischemic stroke, Moya type, focal large vessel occlusions, vasculitis, dissections. And then there's also half of them are hemorrhagic, including intracranial hemorrhages, intraventricular, and subarachnoid hemorrhages. As you can see, the incidence varies a little bit, so it's less than in perinatal stroke, 1 to 2 per 100,000 children. And the kids that are most affected, it's males, less than 5 years old, Black and Asian. The higher risk in kids, one of the interesting findings is there's a very high risk of recurrent ischemic stroke if you have any abnormal vascular imaging. So that recurrency can be up to 66% at 5-year mark. Causes, and we can say sickle cell, congenital heart disease, very important, arteriopathies, vasculitis, any type of infection, even kids that have sepsis and encephalitis are at risk of having those infarcts. Very important diagnostic delays, both for the little ones and the kids. A lot of neuroimaging finding remote infarctions, and we do not have arteriosclerosis in children, but we know that children that are dyslipidemic have higher risk of ischemic strokes. So clinical applications, it's difficult to summarize them all, but basically for stroke perspectives, we can localize where is the steno-occlusive lesion, we can understand the degree of residual flow after therapy, the collateralization around that stroke or that occlusion, the real type embolization, recanalization timing. We can guide hemodynamics and we can do TCD guided therapy. We can also use it for stroke prevention, mostly on sickle cells, as you saw in the first talk for today. And very importantly, we're able to diagnose right to left shunt. So I'm going to share very briefly 3 cases that have opened my eyes on trying to be better at using POCUS in acute setting in stroke and kids that are critically sick. So this is a 12-year-old female with a right M1 occlusion because of a subacute endocarditis with an HIAS score of 17 at presentation. You can see how on the left top side, we were able to reperfuse this M1 occlusion, and it was classified as a TK2C. I would like to show you this video where I'm going up the reperfused vessel, but I want to show you how in the stenotic side, there's a peak systolic velocity around 240. So this is just a few seconds. You'll see how I'm starting from below, and I'm going to walk the Doppler up, and you're going to see the real-time change in the velocity of the peak systolic velocity mainly. So there you go. You can see here the most stenotic part. So we used that to actually make sure that this kid did not have a re-stenosis or re-occlusion that was worsening, and we did not need to send her back to for a second EVT or at least another diagnostic invasive strategy. So in pediatrics, there's not a lot of information about that, but you can see in stroke, it was a publication about can we actually have TCD guiding us the degree of reperfusion? So yes, we can actually, we have 5 grades on how to assess for post stroke therapy reperfusion classification, and it can actually help us understanding stroke severity, clinical recovery, and mortality. Adult evidence regard on all this topic, as you can see here, there's a couple of tables that are fairly interesting. We can study recanalization, arterial reocclusion, air embolization, artery-to-artery embolization, and hyperperfusion. And there's some guiding numbers that sadly do not apply to all the wide ranges on pediatrics. But this patient in this case was almost an adult size, so we kind of use that as a guiding principle. We still have to use our best knowledge in neurophysiology and kind of apply that in every different case. Even if the absolute numbers are not the same, we usually use the trends. Very important, which I find TCD in the identification in the bottom, it's for causes of early neurological deterioration, mostly in kids that we have sedated and ventilated and we can't really examine them. So you can see there's all these causes, but the most important one in this case is the failure to recanalize large vessel occlusions and arterial reocclusion. Very important also to assess for collateralization of flow, and if that collateralization of flow fails, this is also a very important sign to detect. What I'm really obsessed with is TCD-guided therapy or brain-based resuscitation. So what can we do in our hemodynamic therapy to actually improve this patient's brain perfusion? So there's this article that's fairly interesting. It's the only one I have found of TCD-guided blood pressure and intracranial pressure control after acute ischemic stroke. So they were checking for blood flow deceleration and they proved poor prognosis. Intracranial hypertension also increased mortality, and early neurological complications were also very different. So very important to actually be able to, if you use TCD to guide blood pressure, we know we can do better for our patients. Now, how much and when and how often, it's yet to be determined. The second case, it's an 80-year-old with a basilar occlusion because of a dynamic vertebral artery compression, Bow-Hunter syndrome, for those who know the specific names of syndrome. So you can see on the top right how she basically had a total occlusion of the basilar artery, and we were able to reperfuse with EVT. So we decided to do a few follow-ups with TCD. You can see on the very left, there's already an MCA that was hyperemic, and we already proved that was collateralization of flow from the MCA to the PCA with fairly good systolic and diastolic velocity. So we knew there was an anterior to posterior rescue for reperfusing the posterior brain of this patient. You can see that the basilar had fairly high velocities, but was patent both in systole and diastole. 24 hours, increasing hyperemium the MCA, increasing stenosis on the basilar. We repeat the CTA because of this change on TCD, and we were able to see in the bottom where the basilar artery was getting re-stenotic. At 72 hours after, in the patient that's, fully sedated, fully ventilated, very difficult to move and go to CT, CTA. And again, pediatrics, we do not have protocols on how often we have to image kids. I couldn't find the basilar flow, so there was an absolute occlusion. So we actually triggered, in a couple of days, we actually triggered that last image, was an MRA. We knew that she was getting perfused from the anterior circulation, so the urgency to put her back on EVT, and that meant having the adult stroke team come to the pediatric hospital, stop to do their adult cases, and prioritize our care. We knew that was not necessary acutely because we proved she was getting perfused from the anterior circulation. We also proved that she did not have any stroke after this reocclusion. The kid right now just came to visit us 2 days ago and she's alert, talking, walking, swimming, and playing hockey. Third case I'm going to share very briefly. Was a very tricky 15-year-old with a severe hemolytic anemia, cold agglutinin, and he had a moya type disease. I had no idea about that. PICU gets called because the kid had a right side TIA, loss of motor power for 30 minutes, and then contralateral side for 10 minutes. So we basically had this kid that was slightly hypertensive at presentation. The pediatrics team wanted to actually act on that and decrease his blood pressure, but we were able to actually take over at the time. You can see on the right MCA, there's a complete stop of flow, but we were able to find 3 to 4 vessels post-occlusion. So we knew there was some sort of collateralization of flow. And as you see in the bottom, we can actually prove that those collateral vessels had a fairly normal systolic and diastolic velocity, and overall qualitatively waveform was pretty good. On the left side, we actually couldn't see the Doppler signal itself visually, but on the bottom you can see, and it's not the best image, but that's the best we could get, a critical stenosis on the left M1 with velocities that reach above 300. We actually proved those findings with his MRA right after. So you can see here on the right side, there was a full occlusion, and on the left side, there was a critical stenosis. So we were very obsessed on doing MAP augmentation for this kid, and actually we improved his symptoms, and he became from Glasgow 13 to 15, just improving his from his map of like 75 to 100, 110. This kid also left the hospital asymptomatic. What about pediatrics? This is how you feel when you actually try to read literature about pediatric stroke acute management in critically ill children. There's absolutely nothing that's actually done in a very controlled manner. You saw from my colleagues earlier in the day, we have some major clinical trials, most of them focused in outpatient sickle cell. So I'm not going to repeat that information, but stop trial in the late 90s. Now it's standard of care. We do annual TCD for children. There's still a lot of variability. In 2009, the stroke had the first consensus recommendations for transcranial color-coded duplex, which is the one I mostly use for assessment of acute stroke. There's no specification on what adults, what speeds, but at least we had a first attempt to standardize the application of TCCD in acute stroke research. We know that with those guidelines, we can improve reliability and reproducibility of the results for future stroke studies. In 2012, the AUM actually had the practice guidelines of TCD for adults and children, and there's just a little nudge on the indications for children: hydrocephalus, hypoxic ischemic encephalopathy, dural venous sinus patency, on top of all the adult applications. At that time, they were not even saying that we should do angle-corrected TCCS velocities, which absolutely we're doing right now. And then it said it's important to perform those examinations mostly in children when they're awake, quiet, and calm, which honestly never happens. And when you have the patient sedate and ventilating, your numbers changes. No mention of what to do with acute stroke in pediatrics. 2012, these guidelines of sickle cell disease that were based on the STOP trial from 1990s. Basically, this is the only thing they talk about stroke in the context of sickle cell, nothing aside from that. There's this, it's not an expert consensus, not guidelines, but there's a review and in current opinion from Kerry Robert, which is one of our kind of leads on TCD. So it's just basically an opinion about, hey, TCD can be used in stroke. We can use it for ischemic stroke. We can use it for arteriopathies. We can use it in transient or focal cerebral arteriopathy, genetic and syndromic causes. We can actually detect cerebral emboli, right to left cardiac shunt, cryptogenic stroke, and TIAs. So yes, there is the option. Yes, there is the need. There is not yet the expertise nor the guidelines. So in 2020, there was this practice recommendation that Virginie already shared before, which basically tells us that half of the PICUs in North America are actually using TCD to evaluate and manage many indications, but some of them use it for arterial ischemic stroke. Just 8 of the 27 PICUs had actual written protocol. It says in the guideline, in the practice recommendations, we can identify abnormal cerebral blood flow velocities. We can guide therapy to reduce stroke risk in children with sickle cell anemia, yet nothing commenting on the actual management of acute stroke because we just don't have enough data. Very importantly, I loved how they said developmental differences of the pediatric brain, the normal age-related changes of the cerebral blood flow, and the differences in the common pathologies cared for. Simple adoption of adult protocols in pediatric neurocritical care are not possible. 2020, also shared by my colleagues earlier, the ethnic also put their international evidence-based guidelines, which also say we can use POCUS to detect changes in cerebral blood flow velocities in neonates and children's. Pediatric data not yet sufficient to support the use, and caution must be taken when interpreting results. There's no specific stroke recommendations in these guidelines either. There's the Displaced Consortium that I'm not going to touch again, more information about stroke prevention in sickle cell. And in 2019, stroke actually, with the AJA and ASA, through a scientific statement, they talk about stroke prevention in dynamic vertebral artery compression and stroke prevention in sickle cell, yet lacking acute stroke diagnosis and management. In 2021, the French cohort of PICUs did this fantastic review in Frontiers with the conclusion saying, we do use TCD. We perform it early after admission in patients with a broad range of diseases. Physicians have said TCD findings helped their clinical decision making. However, data is still very subjective. It's a bedside interpretation, and we actually need to be all together to set up some guidelines and try to use that in a more global manner. Research gaps, as you know, many, just to say, the very basic one is we don't have reference values for age, for sedated kids, ventilated kids, non-sedated, ventilated, and all these combinations. We do not have TCD and angiography correlations and use a gold standard to actually learn more about TCD. So that's what I try to do, sharing these 3 cases at the very early in the talk. We have very low numbers in pediatrics, very wide age range, and we do have a lot of delayed diagnosis, which complicates our life quite a lot. Feasibility is a huge barrier. And we also like the difference on who does point of care ultrasound TCD, who does diagnostic TCD, and all these details that Virginie and team are actually working on putting their manuscript out. So that's going to help us a lot because we don't have techs that know about that, and we don't have TCD people that are experts and come to PICU to help us every day. So we have to be a bit of self-sufficient. Basic research topics needed, basically the most important one, and I can't stress that enough, is reference values for us. There's a couple of good articles for normal values in children that dates for more than 20 years ago, and one short series from Nicole O'Brien that actually talks about sedate ventilated children, and that's the reference that we can use as a guide. Clinical research topics needed, all of them, seriously. Even if we just talk about stroke, there's so many things we just don't have. And it's again, a rare diagnosis for us with a wide range of possibilities that makes it very complicated. Education gaps, again, you probably, most of you know Wake Forest courses and many other institutions that are doing really good job, but it's mostly adults. We totally lack pediatric resources out of this open care pediatrics. So I was very happy to hear that there's something coming up soon. There's also lacking in teaching in med schools and residencies, just in general, but in pediatrics even more. So we are lacking major courses and curricular for PEDS, and we absolutely do not have competency requirements. Clinical gaps, credentialing, again, it's a big issue. You can be credentialed for adult-based things, but not credentialed for pediatrics. We do not have society guidelines as per consensus statements. We just shared these practice recommendations from 2020, and very happily, soon enough, we're going to have these upcoming focused TCD versus diagnostic TCD guidelines consensus. So if I were to make a wish, TCD should become routine in the neurovascular evaluation of stroke and TIA in children. Thank you very much.